Welcome to this introduction of cardiac surgery. I'm Zhang Zhiwei from the Department of Cardiac Surgery, the first affiliated hospital of China Medical University. Because time is quite limited, this lecture will be very brief. And this lecture will be divided into three parts. That is, history and the development of cardiopulmonary bypass, congenital anomalies, and acquired disorders. Compared with other surgical specialties, the history of cardiac surgery is short, but it has been booming rapidly in the last 50 years. The first documented case of heart repair was reported in 1893 by Dr. Williams of USA. On July 10, 1893, Dr. Daniel Williams, a surgeon from Chicago, successfully operated on a 24-year-old man who had been stabbed in the chest during a street fight. At first, the wound was thought to be superficial, but the patient experienced persistent bleeding and the symptoms of shock. Dr. Williams opened the chest and noticed a tear in the pericardium and a puncture to the heart. The wound was closed surgically and the patient survived. In 1938, Dr. Gross ligated the first PDA on a 7-year-old girl. This operation was thought to be the milestone or the beginning of modern cardiac surgery. And this event was so famous that it has been documented in almost every textbook of heart surgery. In 1948, Dr. Bailey reported the first successful case of a mitral commissurotomy. In fact, Dr. Bailey failed in the previous 4 cases, and the hospital authorities refused his request for further study. So the 5th case was carried out in another hospital far away. This picture I will going to introduce in detail in part 3. In 1945, Dr. Blalock reported the famous operation called BT shunt, that is, Blalock-Taussig operation. The operation was performed by Dr. Blalock at Johns Hopkins Hospital on November 29, 1944. In the operation, the left subclavian artery was connected to the pulmonary artery. So the pulmonary artery got blood flow again, and the blue baby turned pink. Dr. Taussig was the pediatrician, and she supported Dr. Blalock during the process. This operation was considered a very important event in the history of cardiac surgery because for the first time, the human circulation has been altered and has been proved that this operation can improve the cardiopulmonary function. The event was so dramatic that it made headlines on newspapers and magazines. And the event has adapted into a film called Something the Lord Made. Encouraged by these achievements, cardiac surgeons were enthusiastic about doing something within the heart. Making repair of an intracardiac lesion possible, one should bypass the heart. By doing this, it needs a basic understanding of the cardiology of a human circulation and a method to keep blood from clotting, and a device to pump the blood, and a mechanism to oxygenate the blood. The following achievements paved the way for the invention of a heart-lung machine. In 1916, heparin was discovered by J. McLean, a medical student at Johns Hopkins University. And in 1926, a prototype of a blood pump was developed by Dr. Brukhonenko and Tarabinsky from Russia. In 1935, a device perfused the thyroid gland of a cat for 18 days, designed by Alex Carroll and Charles Lindenberg. Among them, Dr. Gibbon contributed more to the success of the development of the heart-lung machine than anyone else. After seeing the deaths of many patients from the surgery called pulmonary embolectomy, in fact, mortality rate was over 80%. Dr. Gibbon thought that if he had a machine to take over lungs and hearts during the procedure, those patients would have been saved. So over the next 20 years, Dr. Gibbon and his wife, Mary, devoted their attention to the program. Though distressed and with failures and frustrations, the couple continued. With the support and assistance from IBM Corporation, the prototype of a heart-lung machine came into clinical use finally in 1955. You see, the left picture shows the blueprint of the prototype of a heart-lung machine. You can imagine how big and how clumsy it is. The other picture shows the modern type of heart-lung machine, the small and exquisite. During the development of a heart-lung machine, Dr. Lillehei from the US proposed a wild idea called cross-circulation. On March 26, 1954, Lillehei and colleagues used the technique to correct a child with VSD. During the procedure, a parent was connected to the child to support the child's circulation during the operation. This technique was abandoned after the successful use of a heart-lung machine in 1955, though the method was short-lived, but it was a stepping stone in the development of cardiac surgery. So this slide shows the mechanism of CPB. The blood is drained from the vena cava by gravity into the venous reservoir, and then the blood is pumped back into aorta after being oxygenated. So with aorta cross-clamped and the vena cava snared, the whole heart is bypassed, providing a motionless, a bloodless field for surgeon, making repair of intracardiac lesion possible. This slide shows the components of a CPB circuit. The first one is a roller pump, the device to pump the oxygenated blood back into the body. You can consider it as a heart. And the second one is an oxygenator. It's the device to turn the blood pink. And that is the heat exchanger. It's modulated the blood temperature. And the filter, who can remove the debris from the circuit. And the last one is the venous reservoir is a device to hold excessive volume of blood. Because the process of a heart-lung machine is not physiologic, so other measures have been used to increase the safety of the operation. Low body temperature can reduce tissue oxygen consumption. 1 degree can reduce 5 to 6% of oxygen consumption. Thus, cooling the body can prolong the time limit of a cardiac operation. Another important issue is called myocardial protection. It's also called cardioplegia. Because in clinical practice, after a long time of heart arrest, the following phenomenon has been noted. That is myocardial edema, functional depression with permanent damage, or even called myocardial cell death. So, cardioplegic solution must be administered during the heart arrest every 25 to 30 minutes. There is no clearly defined time limit for heart arrest, but the clinical data shows that it is safe up to 3 hours. Regardless of the protective effect of the cardioplegic solution, the operation should be finished as quickly as possible. Currently, it is estimated that over 1 million cardiac operations are being performed each year worldwide with the use of a heart-lung machine. In most of the cases, the operative mortality is quite low, approaching 1% for some operations. ECMO is a modified form of CPB, has been proved to be life-saving in the combat against COVID-19. Little thought is given to the courageous pioneers in the 1950s whose monumental contributions made all this possible. This is the end of part one. Thank you very much.